Cardiovascular drugs, Chapter 11. This is one of the most important chapters. You will need to refer back to Chapter 3 on the autonomic nervous systems. Cardiovascular disease are diseases of the heart and blood vessels, and the leading cause of death in the U.S. About 25% of the top 200 drugs used in the U.S. are cardiovascular, and there's 6 out of the top 20. That may be a little higher now. And these are drugs for hypertension, angina pectoris, coronary artery disease, a cerebrovascular accident or stroke, and congestive heart failure. Hypertension is the most common cardiovascular disease. It's known as the silent killer because, as you have seen in the clinic, there's a lot of people walking around with elevated blood pressures that have no idea that they have elevated blood pressures. It increases with age, it's higher among women, and it affects organs, not only the heart, but the kidney, the brain, and the retina. So when we measure blood pressure, we measure it as systolic pressure over diastolic pressure. And systolic pressure is the pumping out or contraction of the left ventricle. That's the pressure forcing the blood out. Diastolic is the relaxation of the left ventricle, allowing for refill with blood. Okay, this was the old categorization of blood pressure guidelines. I'm going to give you the new ones. Normal is considered 120 or less, and diastolic 80 or less. Elevated is considered 120 to 129 over 80, and stage 1 is now 130 to 139 over 80 to 89. Stage 2 is now 140 over 90. So you see we have lowered the recommendations. And there's been much more emphasis on making lifestyle changes, and they're putting people on medications at a much earlier time. And we hope over time this is going to prevent some major heart disease. Hypertensive crisis is 180 over 120. So again, your book has the old stages. I'm giving you the new stages. Now, in hypertensive crisis, you would not even begin to think about treating the patient. In fact, you would send them to their PCP or to the hospital. Okay, essential hypertension. This involves most cases, 85 to 90% of most cases. It's also known as idiopathic or primary. It's often of an unknown cause. And secondary hypertension, which is 10% of all cases, is associated with a specific disease involving the endocrine or renal system. Malignant hypertension occurs in about 5% of the cases. It's a very high blood pressure and rapidly raising, and this can be a very dangerous state. Here's some of the major risk factors for hypertension: smoking, obesity, sedentary lifestyle, alcohol, stress, male, female history or family history of cardiovascular disease, post-menopausal women, and sodium intake. And nowadays, probably the biggest ones here are obesity and sedentary lifestyle. People have not been nearly as active as they used to be. And so we see a lot more overweight people walking around. There are three factors of blood pressure. First, there's the blood volume, and this could depend on fluid loss for the blood volume. We have a major blood or fluid loss, and so there's less stuff to pump around, don't get good perfusion, or it could be from fluid retention, which is modulated by aldosterone, an antidiuretic hormone. There's also the peripheral resistance of the diameter of the arterioles. Are they dilated or constricted? And this is controlled by the sympathetic nervous system. There's a mechanism of action where renin works with angiotensin 2, and we're going to see that chart in a moment. And if we have an increase in blood viscosity, it's going to be a little more resistance. Then there's cardiac output. Stroke volume, how much is there before the heart contracts, the power of the contraction itself, and the afterload. Heart rate is also controlled by the sympathetic and parasympathetic nervous system, and it can be affected by epinephrine. So basically, cardiac output is volume times heart rate. And most of us have about 5 liters of blood in our systems. So what do we want to do to treat hypertension? Well, lifestyle changes are the mainstay therapy. This is where the physician starts. Lose some weight, get some more exercise, eat a diet rich in fruits and vegetables, decrease your amount of fat dairy products, and reduce sodium intake. And the goal used to be 140/90. Now we want patients to be about 120/80. Now you'll see in the clinic that we sometimes have several patients that never get better than, say, 150/90. And when we talk with their physicians, they say, well, for that patient, that's good because that's as good as they get. And they may be on multiple blood pressure medications trying to just maintain this. So you have to do a consultation with the patient's physician to determine if this is as good as it gets for them. There are 5 major types of drugs for hypertension. Diuretics that help us dump water off the system, decreasing blood volume. Beta blockers calm down the sympathetic nervous system. Calcium channel blockers that actually work by blocking the actual calcium channels. And angiotensin converting enzyme, or ACE inhibitors. And we'll see more about that in one of the next upcoming diagrams. And angiotensin receptor blockers. So with any of these drugs, of course, you can have orthostatic hypotension. So you want to be careful when you have your patient reclining to set them up slowly, have them just sit there and get their blood pressure regoing before you have them jump out of the chair. Otherwise, you will have a patient that passes out. This happened to me, a young man that I took a tooth out on, and he was trying to compensate by pulling his blood out in his extremities. He was nervous, and so his blood pulled out in his extremities, and then when he jumped up out of the chair, he passed out. Fortunately, he was fine, but I should have been more aware and just set him up slowly and tell him to stay there And now I do that, especially with male patients, because they tend to try to white knuckle it. Thiazide is a commonly used diuretic, and you'll most often see this as hydrochlorothiazide. It's the most common. Now, one thing to remember about this is that NSAIDs can actually reduce the effectiveness. So you want to treat the patient who is taking a thiazide, limit them to a cardiac dosage. Loop diuretics are strong cousins of thiazides. They just work at a slightly different place in the kidney. They inhibit reabsorption of sodium, so that promotes diuresis or urination. And there are some that are potassium sparing. These are a little more puny, not quite as potent, but you don't have to worry about putting the patient on potassium supplements. Then we have beta blocking agents, beta adrenergic blocking agents. These end with the suffix olol. So if you see an olol drug, that's a beta blocker. These work at the beta 1 receptors in the heart and the beta 2 in the lungs. They lower blood pressure by decreasing cardiac output. Side effects can be bradycardia, mental depression, decreased libido, xerostomia, and they are a concern for us because the Medicaid patient may have a 2 to 4 times increase in vascular pressure when given epinephrine, especially if the beta blocker is a non-selective beta blocker. So you want to eliminate or limit the dose of epi to a cardiac dose. Again, that's 2 carts. Okay, look at this slide carefully. I want to point out something on here that's wrong. Calcium channel blockers do end the suffix PINE. So if you see PINE, that's a calcium channel blocker. They do inhibit calcium ion influx, and this produces vasodilation. It doesn't reduce vasodilation. It allows the blood vessels to remain vasodilated. They also reduce the afterload on the heart, so you have less blood flow that's left in the heart. And this is useful to treat angina pectoris and hypertension. They're one of the few antihypertensive drugs who are not affected by NSAIDs or COX-1 analgesics. So please highlight that. But remember, they cause vasodilation, thereby reducing blood pressure. The side effects are pretty much the result of the pharmacological effects. You can have excessive hypotension, which may cause some dizziness and lightheadedness. Bradycardia and edema may result, shortness of breath, and xerostomia, and particularly 2 of these, nifedipine and amlodipine, are associated with gingival enlargement. Then we have ACE inhibitors. These end in the suffix pril, such as in lisopril. They reduce angiotensin II formation, which is a vasoconstrictor. So with that, they cause vasodilation, provide for renal sodium elimination to drag the water with it, reduce volume, water elimination. And some of the side effects are dysplasia, hypotension, rash, and angioedema. They are a teratogenic factor of X, so you would not want to use these in the pregnant female. And we have angiotensin receptor blockers. And these attach to the angiotensin II receptor and blocks the effect there. And this is a good diagram. I want you to really look at this and learn it. Suppose our blood pressure falls, our sodium levels fall, the sympathetic tone decreases. Renin is released to convert angiotensinogen into angiotensin 1. Then there's a converting enzyme that converts 1 into 2, and an ACE inhibitor stops that at that step. Because if it goes on to aldosterone, we have increased sodium retention and plasma volume, and the angiotensin 2 causes vasoconstriction, and both of these factors raise the blood pressure. So this is the mechanism where the body regulates itself by controlling the release of renin. And this happens in the kidney. Okay, so the patient on any of these medications needs to have meticulous hygiene, increased frequency of recare visits, because they're going to have xerostomia. They're much more prone to get decay, and they'll have dysplasia. And the calcium channel blockers, again, can create gingival enlargement. And that's primarily nifedipine and amlodipine. So really good hygiene is necessary. What are the adverse drug effects of these? Well, orthostatic hypotension, we know what that is. We have to set the patient up slowly, have them sit there in the chair for a moment. Constipation, which can be additive with opioids, and increased dietary fiber, bulk, or laxatives to help with this. And in addition, they have a little bit of CNS sedation. So if you have other agents on board, they can be additive to that CNN depressant. Vasoconstrictors. The majority of cardiovascular patients should benefit from use of epinephrine and local anesthetic. Why is that? Because if you hurt the patient and put them into fight or flight, they're going to dump more endogenous epinephrine than you would ever give them. But you do want to limit your dose, and that's 0.04 milligrams. You should know that by now. Use a slow rate of injections. Use an aspiration syringe so that you are able to aspirate. And how many carps is that? Generally 2. If you're using lidocaine with 1 to 100,000 epinephrine. Okay, so here's a little algorithm for hypertension. Begin or continue with lifestyle modifications. If that doesn't drop enough, add a drug, usually in uncomplicated hypertension. That's going to be a thiazide diuretic to start out with. You may consider ACE inhibitor or beta blocker, calcium channel blocker, or a combination. If it gets to stage 2, we're going to use at least a 2-drug combination. And we have to consider, too, about comorbidity. In diabetes, the most helpful blood pressure medication is an ACE inhibitor. And in heart failure, the most helpful is an ACE inhibitor or diuretic. Get the volume of water off the system. And in elderly, you can usually do this by diuretics or long-acting calcium channel blockers. In myocardial infarction, heart attacks, we can use beta blockers or ACE inhibitors. If they're not at the goal blood pressure, you can optimize the dosage or add drugs. And we have seen patients in the clinic that may be on as many as 4 to 5 antihypertensive drugs. Here's a diagram showing where the different drugs act at different sites. It's very specific. I would like for you to know this pretty well. Now we're going to talk a little bit about coronary artery disease, and this is caused by atherosclerosis. This is from dyslipidemia and hypertension. What is dyslipidemia? Well, that's buildup of plaque in the blood vessels, and it is characterized by a decrease in oxygenated blood to the heart muscle during times of increased demand. Ischemia is a temporary deficiency of O2. Myocardial infarction from permanent O2 loss will lead to necrosis, and that's a heart attack. Here's a picture of the atherosclerosis. You can see the lumen of the vessel becomes occluded by platelets and fibrin deposits on plaque, and they start a clot formation, and then that partially occludes the lumen, and then that can go on to completely occluding the lumen and then the stop of blood flow. Angina pectoris is when the metabolic demands of the heart exceed the ability of the coronary arteries to supply adequate blood flow and oxygen to the heart. The majority of myocardial ischemia, reduced blood flow, is due to these plaques or atherosclerosis. Here are some risk factors for angina pectoris: smoking, elevated serum lipids, a family history, obesity, the male gender, a sedentary lifestyle, hypertension, and a type A personality. Well, we can't really control family history or what gender we are, but we can control obesity, smoking, trying to tailor our diet so we decrease our lipids and get more active. And then hypertension, we can either manage medically, sometimes by losing weight, you can get off your blood pressure medications. And then a type A personality. Well, these people may need to learn to chill out. Okay, there's stable angina. Just means they have chest pain intermittently on exertion, but if they rest, they're okay. And this chest pain can radiate to the left arm, the right arm, or both in the jaw, and the shortness of breath and nausea, vomiting, and sweating. Unstable angina occurs when oxygen demand exceeds the oxygen supply at rest. So the frequency and severity of attacks increase. And many of the same drugs that are used for hypertension are used for angina pectoris: nitrates, beta-1 blockers, calcium channel blockers, aspirin to inhibit platelet clotting, lifestyle modifications, cholesterol reduction, and homocysteine reduction. And here's a chart. This is also from your book. Please look this over and become very familiar with this. Congestive heart failure is when the heart cannot keep up with the oxygen demands. The cardiac output is inadequate. That patient may have poor circulation, but over time, the blood accumulates in the failing ventricle, and the ventricle enlarges, and stretched cardiac muscle extends beyond its effective limits. Okay, in the case of heart failure, that can occur on one or both sides of the heart. If it's on the left side that's failing, we will have pulmonary edema and dyspnea and orthopnea. So the patients may need to sit in a semi-reclined position. Dyspnea is shortness of breath. Orthopnea is shortness of breath when reclining. So the patient may need to sit up. If it's on right-sided, the right side of the heart is failing, that has systemic congestion because it's backing up everything that goes back to the veins. Congestion is evidenced by pitting edema, and this is usually around the ankles. And you'll also see patients in our clinic that have enlarged ankles. That means their heart is failing to keep up with the blood volume. So the right side of the heart is failing. If the left side of the heart is failing, they won't necessarily have this pitting edema, but they will have shortness of breath due to the pulmonary edema and orthopnea. How do we treat congestive heart failure? Well, a lot of it's the same things that we use for hypertension. Diuretics, these decrease the workload by taking fluids off the system. Cardiac glycosides, which increase the action of the heart contractions. ACE inhibitors, calcium channel blockers, direct vasodilators to decrease cardiac output and blood pressure, and beta-1 blockers. So a lot of the same drugs that we use for hypertension. Beta blockers work, of course, by reducing the sympathetic stimulation to the heart. Remember, beta-1, heart, beta-2, lung. Cardiac glycosides is the most common product, and this one, the prototype is digoxin, also known as lanoxin. It increases the force and strength of the contraction. The heart can actually do more work without additional oxygen, so this makes the heart more efficient. The heart rate is increased in patients with chronic heart failure, so digoxin helps that by reducing edema, by improving kidney circulation and dumping fluids. So the heart size is reduced as excess blood volume is removed. Digoxin is also used for atrial arrhythmias, and we'll talk more about those in a moment. What are some of the adverse effects with these cardiac glycosides? Well, we have GI toxicity that will show up as anorexia, nausea, vomiting, arrhythmias if you have a high enough dose, neurological signs, visual disturbances such as green and yellow halos, halos around lights, increased salivation, and you have to use a cardiac dose of epinephrine. So just two cartridges of lidocaine with 1 to 100,000 vasoconstrictor epi. Some of the vasoconstrictors can create some arrhythmias, drugs that mimic the sympathomimetics. Erythrin and tetracycline can increase the blood levels of cardiac glycosides. So you want to be careful using these with someone taking a cardiac glycoside because it could push that cardiac glycoside into a higher level. Vasodilating drugs work by reducing the workload of the heart, decreasing the cardiac output, decreasing the peripheral vascular resistance. That means the blood vessels dilate. It decreases oxygen demand, which relieves symptoms. Now, this is not curative. It is merely treating symptoms. Fast-acting is amyl nitrate. This used to be popular on the disco floor when I was younger, and nitroglycerin. The ADEs are severe headache and hypotension. So if you're going to have a heart attack, most of the time it's going to happen in the morning. So for a cardiac patient, you may want to consider afternoon appointments for them Make sure you get good anesthesia so you don't cause them to dump their own epinephrine into the system. And if a cardiac episode chews, you have them chew up an aspirin and put on oxygen and nitroglycerin. But yes, you do have to ask only if they have not used an erectile dysfunction medication in the past 36 hours. And you can continue to administer the nitroglycerin at 10-minute intervals while you're waiting for the EMS. Well, normally in the heart, the SA node is the pacemaker. It regulates the autonomic nervous system to about 60 per 100 beats per minute. The AV node fires the ventricles, and the interruption of the process, this process leads to an arrhythmia. And this can be a signal of an oncoming myocardial infarction. And this can either be a bradycardia, a slowing of the heart, or a tachycardia, a rapid heartbeat. And here's the class of some of the antiarrhythmic drugs. You notice there's actually a lidocaine in there. But again, do not take lidocaine and stab it into the heart of your patient that you believe is having a problem with arrhythmia. That's for the emergency department. What are CAD risk factors? Well, cholesterol, which builds up that atherosclerotic plaque within the vessels, triglycerides, and elevated LDL. Now, we have different types of cholesterol, but elevated levels can lead to stroke, myocardial infarction, and hypertension. You want the overall LDL or cholesterol levels to be below 200, and you want the LDL to be below 130. Your good cholesterol is your high density lipoprotein. So that's over 35. That helps to be protective of your heart. Okay, I want to go back and talk about something that I failed to mention earlier. In the patient taking medication for hypertension, you do want to use some restrictions with epinephrine, but what you don't want to do is use carbocaine with neocorveprin, because the neocorveprin actually activates the alpha receptors and can cause stimulation. So just keep that in the back of your mind. Don't think that you could go get carbocaine with neocorveprin and be fine. That's not actually true. Now I want to talk about treatment for hypercholesterolemia or hyperlipidemia. We can treat this with HMG-CoA reductase inhibitors. There's a good picture in your book about how this works. The most widely used anti-cholesterol are statins. It interferes with cholesterol synthesis in the liver. Lipitor was one of the early ones, Crestor, Zocor. What you need to know is that some of these drugs interact with some antifungals, such as macrolides, erythromycin, and clarithromycin. And one of the other things they interact with is grapefruit juice. Grapefruit juice inhibits, it has an effect on the liver enzymes. And so there will be an interaction between it and some of these antifungals and the drugs for the statin drugs, and also it actually affects another drug called Synthroid, which we'll get to later. But enough about that. Let's move on. Other drugs available for high cholesterol are nicotinic acid, which is provides a 20% decrease in the LDL. It's a 30% to 70% decrease in all triglycerides, and it does help increase the good cholesterol a little bit. But again, it can cause a problem with orthostatic hypotension. And then there's Zetia. Zetia inhibits absorption in the small intestines. And then there's Vytorin, which is a combination of Zetia and a statin, simvastatin. We also have drugs to break up thrombi or clots. And these restore myocardial contraction. It helps prevent thrombus formation. An example of these are Plavix, and there are some that prevent coagulation, and these are warfarin and heparin, also known as Coumadin. Warfarin is, and these help prevent deep vein thrombosis and pulmonary embolism. And you may find several patients that are on warfarin, and what we need to know about those patients is what is their INR, and is it safe for us to treat them? So, following that up with warfarin, it interferes with vitamin K clotting factors. It has the adverse drug effect of severe bleeding. It can require about 3 days to clear the system, and you need to know the INR so you can make sure you're going to be okay clotting up. Now, many physicians will tell you that patients are too likely to have a stroke, and so they say deal with the bleeding and don't take them off the warfarin. So this requires a physician's consult. There's also Persantine, which is used post-surgically with valve replacements. It inhibits platelet adhesion and prolongs the platelet life. This helps with anti-clotting. Okay, so if you have a pacemaker, you don't need antibiotic prophylaxis. If it's not properly shielded, you may get some interference from some dental instruments such as ultrasonics. If you're not sure, put an apron over the patient, an x-ray apron, and consult with the patient's provider would be helpful. Now, most of the time, patients now have, I think they're almost always shielded. So you can find out from the physician, they'll have that in their records. And if you've managed to keep your sanity and tolerate me, then so far you are surviving pharmacology. Good job.